Okay. All right. Thanks for inviting me to talk. We'll be talking on the treatment algorithm in pulmonary arterial hypertension. And good, there we go. So, my disclosures. And then, so just a pretty short outline the treatment algorithm, and then what's new since the World Symposium about a year ago. So, we'll continue discussing sotatercept mostly. And then I have a PH case. So, I thought it would be useful to start with other algorithms and changes over time because I think it's interesting to see how things have progressed through there. So, I started with 2015, which is the year that Ambition also was published, and which I will show in a little more detail in a minute because it was a really important trial, but it's what really changed therapy to the point of at least considering upfront combination therapy. So the guideline that came out that year from the Europeans had two pathways: initial monotherapy or initial combination therapy. Both were considered options at this point. By the World Symposium in 2018, we have the bigger box for combination therapy, and then off to the side, using a smaller font, is there a residual rule for monotherapy? And they have a discussion in the paper about when one might consider that. And then finally, for the 2022 guideline, they sort of get rid of the monotherapy arm because this is for the PH patients without comorbidities, so the general algorithm, and it's basically just start upfront combination therapy. But they introduce this: patients with comorbidities, should these patients be treated with a monotherapy approach because maybe they have a higher complication rate with medications and so on. And I'll talk about that in a little bit in just a minute when we get to the World Symposium algorithm. Treatment then, or risk assessment then, is reassessed at 3 to 6 months, and then add-on therapy is considered. And then in the 2022 guideline is the first time that we see the 4 risk strata rather than 3, and this was acknowledging the intermediate group is quite large. Second, there's a significant difference in prognosis for these patients, and then the number of treatments have been expanding and expanding, and so there's more options for where one goes with therapy. Okay, so then moving on to the World Symposium algorithm from that was published in 2024. This has already been shown in some detail, so I'll go through reasonably quickly. One of the most notable things is the lack of the comorbidities arm for this. And this was based on reviewing what data we have on patients with comorbidities and looking back at the clinical trials. Somewhere in the 30 to 50% range of patients in these trials have at least one cardiovascular comorbidity. It's actually hard to come up with a number because often it's just listed by individual comorbidities rather than the aggregate. But in trials like Griffin did show it in aggregate, it was 50%. In Ambition, I think hypertension alone was about 30%. So it looks like it's going to be at least in that range. And with those types of numbers, as well as studies that have attempted to look at outcomes for patients with comorbidities showing benefit, perhaps smaller, we felt that there wasn't enough data to say we need a whole separate algorithm for these patients. However, at the very top, we have this algorithm is intended for patients who have phenotypically fairly straightforward PAH. And for the really complicated patients, one, we're increasingly recognizing that some of those don't have PAH at all and shouldn't be treated with monotherapy or PH therapy in any way. So get the diagnosis right from the beginning. But for the patients that do have more phenotypically clear-cut PH, should be treated following the algorithm. Okay, so then initial therapy, I think this we've gone over. That's fairly straightforward. The time frame for when one should reassess patients is not 100% clear. There's not been trials studying this. Most clinical trials, however, allow enrollment if you haven't met whatever their entry criteria are within 90 days. So assessment at 90 days, that was enough to go into most of the combination therapy or add-on therapy clinical trials. So we thought that was a reasonable time frame to reassess. That is patients who are doing reasonably well. In addition, if a patient is obviously deteriorating before you get to this time point, then reassessment and add-on therapy is where one would go. So if you started out not high risk, but within your first 3 months, things are not going well, this is an alarming sign, probably worse than being high risk in the first place. You're not responding to your initial 2 therapies, and escalation is reasonable. Okay, and then we'll spend more time here because this was the more complicated portion of the algorithm. On either end, I think it's fairly straightforward. The low-risk patient, for the most part, not Val's patient that we looked at earlier, who was low risk by perhaps walk function class NT-proBNP, but not really low risk by echo if we were using a assessment tool that included echocardiogram. But the other low-risk patients continue initial therapy, close monitoring, watch for deterioration. At the other end, we've got the intermediate high and the high-risk patients, and for these patients, add-on therapy, the main question was, if they were only on 2 orals, do you add IV therapy next, or do you add sotatercept next? For many of these patients, they're going to require both, honestly. But which one to go to next? Well, from a convenience standpoint, we know what's probably happening in the real world, but I think we want to remember not to underuse the IV therapy treatments, as many, many patients in the sotatercept studies were on it. In Zenith, for example, it was 59% were on IV therapy. And then finally, maximal medical therapy is 4-drug therapy now with an ERA, a PDE5 or riociguat, sotatercept, and then parenteral therapy. We'll spend some more time talking about the intermediate low-risk patient group, though, because that's where we have the most treatment options to consider. Okay, so the trials that influence that initial therapy, and you've seen that it's not new for this algorithm. This has been going through all the way back to 10 years. Upfront combination therapy with an ERA and PDE5 really started with ambition. Prior to that, there was solid data that for patients not achieving goals, adding a second drug was beneficial, but there wasn't upfront data. And this study was really impressive that they got it off the ground at all. There had been a strong desire to have something like this for a very long time, but at the time, ambrisentan and tadalafil, so even tadalafil, were both branded drugs that were made by different companies. And so to get this study to happen that's a challenge. And they managed to pull this off with randomized 2-to-1-to-1 ambrisentan and tadalafil versus ambrisentan versus tadalafil. And then they looked at the pooled monotherapy. So they took those 2 groups together and looked at long-term outcomes and showed a 50% reduction in time to event, much greater improvement in walk, much greater improvement in NT-proBNP. And then there was a hemodynamic sub-study that was just specific centers that published basically their own data. But there's subsequent studies that have shown similar results. You get about twice as much improvement in PVR. It's in the 50% range versus 20 to 30% that you typically get with monotherapy. So that, along with some subsequent studies that influenced not doing triple therapy and some others studies that added some confidence to the upfront ERA and PDE5 combination are shown here. So we have ambition that we just talked about. The ADO study looked at patients treated with macitentan and tadalafil, so macitentan rather than ambrisentan. A majority, but just a slight majority, were treatment naive. The other half were on either a PDE5 or an ERA and came into the study and then were randomized to this treatment. And PVR was the primary endpoint, and they showed, again, much larger improvements in PVR with upfront combination therapy. They also showed improvement in NT-proBNP, did not reach walk distance, significant differences in walk distances, but numerically, combination therapy also led to greater improvement there. Then we have our negative trial for triple upfront therapy. So this was Triton looking at the macitentan, tadalafil, and then plus minus selexipag combination, 3 drugs versus 2 drugs. The primary endpoint was PVR. It was reassuring in the sense that there was a very large drop in PVR in both groups. It was in the 50-ish% range, but no difference. And no difference in NT-proBNP and no difference in walk distance. So upfront triple therapy is not recommended, and this is where we stick with the combination ERA PDE5. And then finally, the sildenafil affiliate study, and I have a slide on this one, so I'll go ahead and go to that. So sildenafil is interesting in that the original phase 3 study of sildenafil looked at 20, 40, and 80 milligrams, and the primary endpoint was 6-minute walk distance, and there was no difference across those doses. However, there were hemodynamics in this study, and the hemodynamic improvement with 20 milligrams of sildenafil is actually quite modest. It's in the teens. It's a little lower than most drugs, whereas with 80 milligrams of sildenafil, it was about twice that. It looked pretty good. But the FDA approved only the 20 milligram dose because the primary endpoint was walk distance and there was no difference. In addition, there was a pediatric study that had some concerns about high dose sildenafil in kids. There was an increase in deaths, very small study, not sure what to make of it, but the FDA had concerns. And so they actually mandated this study. And I think it's interesting. So they looked at 5, 20, and 80 milligrams. It's designed as a non inferiority study. And they found that 80 was not inferior and probably better than the other doses, or certainly at least versus 5 milligrams. It's not as convincingly better versus 20, but there were no safety concerns whatsoever with the high dose and with slightly better numerically outcomes with it. The FDA changed the label, which now reads start 20 milligrams, no different, but can consider up titration to 80. Now, most patients, we use tadalafil. It's once daily. It's more convenient, and I think adherence is better. But some patients have insurance issues or tolerability issues or whatever. So at least in the back of your minds, that should be there. Now, these lines you can see between the green line is 80 and the blue line is 20. It's not markedly different, but there were no safety concerns whatsoever. And with that, plus the earlier hemodynamic data, to me, I would at least consider it, except that it's so many pills. So I just put people on tadalafil whenever I can. Okay, so then, I don't remember what I was gonna say here. Oh, now, okay, yeah, so moving on to the, follow-up. This is actually a lot messier, so let me show you the studies that we looked at. So this was what was available at the time of the World Symposium, and the question you're asking is, 1, should we add medications? But if we should, which one? And to answer the which one question, you need head-to-head studies. I mean, that's the way you do it. Is drug A better than drug B? Head-to-head, same population, randomize the whole deal. And we don't have that. So that makes it really difficult to make really strong recommendations. In clinical practice, you still have to pick something, though. And it would be nice if we reach the point where we have some consensus, and maybe we will. We have more data now than we had at this time on sotatercept. Oh, sorry. What we had at this time was sotatercept versus placebo, the oral and inhaled prostacyclin pathway medications versus placebo, and riociguat, which was a little more complicated, patients on a PDE5 randomized to either continue it or go on riociguat. So the studies were all randomized and are useful in answering the question, should we add on therapy in patients who aren't meeting treatment goals? This is where we are now. So 2 more sotatercept studies, otherwise essentially the same table. And so going through that, should we add on therapy? Some of the basics that are looked at are, first, was the study blinded? Mostly, but actually that riociguat study wasn't. It was a difficult design to blind, and they made the decision to blind the person assessing functional class and walk, which made it tricky. You had to have all these different people assigned to the study. The patient knew what they were on, the investigator knew what they were on, but the assessor did not. So that somewhat lowers the confidence in the results, especially when you're dealing with somewhat soft endpoints, like how do you feel, what's your functional class, and maybe even walk. It's a concern. Second was, are these the patient population that we're talking about adding on therapy to? So for that, we would like patients to be on ideally 2 drugs. Most of the studies were not. The sotatercept studies did have many patients on 2 or even 3 drugs, most patients, in fact. Griffin had 1/3 on 2 drugs. And then for the rest, it's mostly monotherapy, except for the 2 freedom studies that were negative. That said, there's a very large difference in what we see when we do trials in treatment-naive patients versus one drug. It's not as clear how much of a difference there is if you do a study of add-on therapy in 1 drug versus 2 drugs versus 3 drugs. So the difference seems to be smaller, I will say. All right, then next thing is what was the study results and what was the primary endpoint? And so I've got the column there with all of the yeses. That's the studies that met their primary endpoints. I've got what the primary endpoint was, 2 columns to the left, and then the distance. So nearly all of them, the only studies that didn't were the 2 earlier Freedom studies looking at 6-minute walk as the primary. They did have the follow-up Freedom EV that both changed to TID dosing, which increases tolerability, get the dose up a little bit higher, and then looked at long-term time to event, and it was a positive study. So, yes, most of these studies were positive, but then the final thing to look at is, does it meet a clinically meaningful amount of improvement? And, it depends. If we just look at the 6-minute walks, a whole bunch of those don't. We've got 10 meters, 12 meters, some studies that didn't improve functional class. Griffin, for example, is really small improvement in 6-minute walk. That wasn't the primary, though. The primary endpoint was time to clinical worsening, and there was a 40% reduction in that, and that's large and meaningful, I think. But it makes it really hard to compare across studies. And then we're very tempted to, well, let's just look at the magnitude of improvement, but look at the sotatercept studies. We've got 6-minute walk distance improvement ranging from 21 meters, which wouldn't meet the minimally important difference that most studies have suggested, it's up in the 30 or 40 meters, and then Zenith with 60-something meters. So big differences there, which is why if you're really going to compare, ideally you have head-to-head studies. But I think this will be a good something to talk about. What do you actually do? So, oops, go back one. So in the intermediate low risk, what's written in the guideline or in the Seventh World Symposium guideline or algorithm, sorry, it's not a guideline, is an algorithm, expert consensus conference. Let me get that right. What was written was, we do recommend adding therapy for patients not achieving low risk, and you could consider an activin signaling inhibitor, an oral or inhaled prostacyclin pathway agent, as sort of first line, higher level of evidence, and then also can consider switch from PD5 to riociguat, but because of the lack of blinding, doesn't get quite as high of a recommendation. So for sotatercept, though, where are we now? At the time of the Seventh World Symposium, we had the Pulsar phase 2 trial, and then we had Stellar, which was 323 patients, functional class 2 to 3, PVR greater than or equal 5 Wood units. Overwhelmingly positive study. It was 6-minute walk distance as the primary and 41 meters, which is very solid when you consider how many patients were on 2 and 3 drugs there. But the secondary endpoints that improved, I think, is really where you get the big picture. This is going to be a big drug for us. So we see improvement in symptoms in PVR, NT-proBNP, function class, time to clinical worsening, even though it's a relatively short duration, French risk score, and then the PAH SYMPACT, which has 3 parts, 2 of 3 improved. And then you get to the final thing on their secondary endpoints, which was the cognitive emotional impacts, which did not improve, but everything else did. Since then, as we've seen today, we have Zenith, which looked at the higher risk patients with a reveal light score greater than or equal to 9. Their primary endpoint was a composite, as we're used to seeing, but it included only the death, transplant, hospitalization. It didn't include the worsening of 6-minute walk distance with functional class and that sort of thing, which they overwhelmingly met. The hazard ratio here is 0.24, so let's see, over 75% reduction there. And then approached meeting survival benefit all by itself, did not hit the overall survival, but if you looked at transplant-free survival, the hazard ratio was 0.34, and the confidence interval there doesn't cross 1. So impressive study for high-risk patients. And this was halted early based on a pre-specified interim analysis. And then finally, Hyperion, this was the reveal light greater than or equal to 6 or compare greater than or equal to 2, which is to hit that really just takes one of your severity measures looking bad. So patients with fairly mixed results could be doing okay on walk, but have a high NT-proBNP or vice versa, could very well get into this by the ComparaScore assessment. And here, the primary endpoint is death, transplant, hospitalization, septostomy, and decline in exercise capacity. So with a less sick patient population, important probably to add that in because it becomes a relatively common endpoint. And again, and we see a really large reduction in the primary endpoint there. Much smaller improvement in 6-minute walk distance of just 21 meters between the two groups. And interesting, the placebo group increased their walk distance by 16 meters. So, which I think reflects the relatively new diagnosis, and they had to be on therapy for, I believe it was 6 months. There's also studies looking at echo. I'm going to skip through this and get onto my case presentation that I want to show. But before I do that, the other side of the equation here is the AE side. And I think that's also really important to consider, because if a drug is highly toxic, even if we see a lot of improvement, we may want to try a less toxic medication first, and then if we need to, go on to the other drug, versus if we don't feel a medication has a high level of toxicity and it shows that much improvement. I think that was really pretty overwhelmingly better than what we've seen with many of our existing medications when added to patients on background therapy. Okay, so the anticipated AEs, we have increased hemoglobin, thrombocytopenia, telangiectasias, and then bleeding. And I went through and pulled the rates for the various different studies, just to, partly for myself, try and get like a little better sense here of where we are. Increased hemoglobin, 6 to 12% of the time was reported, hardly ever in the placebo group. Most of the time, not enough for patients to have to come off medication, and in fact, maybe beneficial as long as it's not too extreme there. Thrombocytopenia, also around 6 to 12%, but seen at some rates in the placebo arm as well. So some of this is the PAH, some of this is the medication. In my own personal experience, we have almost never had to take a patient off. We have about 120 patients on, but more concerning, I think, when I'm trying to start patients. Some of my patients who have platelets of 60, and I'm less sure about how's this going to go. The telangiectasias, you can see the rates really jumped up with the later two studies. I think patients were being warned about it, and they would come in trying to show me something that I'm squinting, and I'm not really sure if it's there or not. And do you report it or you not report it? And we report it and watch it, and it does nothing. I mean, I'm not sure it was new. And you can see the placebo arm in Hyperion even had an 11% rate of development of telangiectasias, maybe because there were more CTD patients in there, but I don't know. I think sometimes these were very subtle things. But in any case, I think the take-home message there is that for most patients, these have not developed into a continually progressive thing. And in fact, what develops often regresses. And many of them don't even really look like telangiectasias that I've seen. They look more like cherry angiomas, like little red dots that bleed if you bump them and regress sometimes. All right, more problematic though, bleeding. So I've got the epistaxis and the bleeding events there, pretty high rates overall. I don't know what to make of that, but that's a concern. But this, I think, is really what gets our attention. So small numbers, but people who had hemoptysis, GI bleeding, CNS bleeding, a couple of those, and then the total serious bleeding events numbers across Stellar, Hyperion, and Soteria. It's small, but not zero. And what I don't know, as we start to broaden the types of patients that we're using sotatercept in, especially some of my CTD patients and such, is how are these random events, or could we have predicted it? How do we identify patients that may be at higher risk? And so I think that needs additional work. All right, last two slides on AEs. Intrapulmonary shunts. So we've talked about this. I'm reassured that these were quite small, grade 1 so far, but definitely something we need to keep an eye on. What's going to happen to these folks over time? So this was a study, it's a chart review study. There were 77 patients where it was reviewed, and only 16 had a pre and post bubble study. So we don't have the kind of comprehensive data that we really need yet for this. This is just too small, and probably some of these folks were having bubble studies done for clinical reasons. It wasn't a comprehensive study. In the table, I've got patients who were negative at baseline and negative at follow-up, which was 6. And then there were 7 patients who were positive at baseline and unchanged. That was, they already had an amount of shunt. And then the 3 patients where they became positive. So they had a negative study at baseline, and then in follow-up had 10 to 20 bubbles, which is a grade 1 shunt, and So that's what we know so far. On less oxygen, doing okay, stayed on medication. So I'm sure we'll probably have additional follow-up there. I will say 10 to 20 gets into the range where at least it was probably real. It wasn't 1, 2, 3, but it's pretty small. And these are tricky. And even 10 to 20, I don't know. I've seen some where we all look at it and we're like, I don't know. All right, pericardial effusion. So you already heard my thoughts on that. I pulled up the rates of moderate or large effusions in Stellar and Zenith, which were in the supplements, and they, or sorry, we're not in the supplements, are in a new paper that came out. So the company has put all their data together and did this shift analysis of effusions. They actually don't see an increase, and what you can see here is that although there was a slight increase in the number of patients with an effusion that was moderate or large in both Stellar and Zenith, couple more patients. So that's baseline sotatercept, week 24 sotatercept. You can also see that in the placebo group, a couple more patients. So I think this remains also to be seen what comes of this. So where do we go from here? I think we have larger improvement with sotatercept in both even though I said don't compare cross studies, 6-minute walk, functional class, time to event, but uncertainty about AEs. And so I think we likely will continue to see increasing use there. All right. But how do we make a decision in individual patients? I do still think that there is a role for the oral prostacyclins. I think if a patient is doing reasonably well symptom-wise, but has concerning findings that I'm worried about them progressing, I think there may be a role for that patient there. But they're not going to improve a ton from baseline, at least in most cases. So if a patient is really unhappy or really sick, I think sotatercept may be a better medication for them. Okay, my case, I don't know if we want to bring folks up for my case while yes, okay.
So our panel is going to include Barb LeVarge, who uh, is a long-term UNC professor. She trained in Boston at one of those hospitals and then has been down here. We're lucky, very lucky, honestly, to have her here. She's with Jimmy and she's wonderful. And we're also very happy to have Karla Cruz join us for the first time. She trained out at Stanford and then has been at Prisma Health in South Carolina now for the last couple of years. She's interested in PH as the director of her PH center there, but also very interested in pulmonary emboli. All right. And you're welcome to go.
Okay, very good. And then I know we have lunch right after this, so but no pressure. All right, so I have one case, but I track her for the last 10 years, so we have a few slides on this. So this is a 31-year-old woman. She's obese. She has a BMI of about 50, sleep apnea, no other comorbidities, presents with severe dyspnea exertion, presyncope, and lower extremity edema. She was diagnosed with PH at another institution based on the cath that is shown there. She was started on dual therapy, but developed hives, so the PD-5 was stopped. And so she is on monotherapy with an ERA. Her walk distance is 250 meters. Her NT-proBNP is 1,500. And we do a cath and an echo and end up doing an MRI. So here's that data. So she's got a right atrial pressure of 19, a PME of 58, a wedge of 16, a cardiac index of 2, and a PVR of 7.9. And my slides do play. Excellent. And so there's her imaging. You can see not really looking very good. Big RA, RV, small a, LA, and LV. So I have a question kind of for the audience, and then we'll let our panelists talk. So 31-year-old comes in with this history. What would you like to do now? So add on an oral prostacyclin, add riociguat, add IV EPO, B and C together, and none of the above. So how many of you think this is HFpEF and we should do none of the above? No? Okay. Do
Not
we
with
want to
that echo.
add 2 drugs, 1 drug, 1 drug, 2 drugs? All right, let the panelists talk. What do you think?
Just question before OSA treated, no OHS type of physiology.
No OHS, SATs are normal, and OSA is not treated.
Right. I think that it should be I've definitely had this type of patient with I can't remember if it's drug related or connective tissue with the obesity untreated and just unmasking OHS by VQ upset with drugs. So I think that's always going to be a little bit. I think without that history, I would probably be more on the type of spectrum of having addition of a drug that I feel like is going to be very effective for her with that RA pressure, with that index. But I think the untreated OSA is going to give me a little bit of pause as
So
well.
her OSA was not severe,
Okay.
but it is present. We do start treatment, but we end up treating. And she has a wedge that's high though, right? So this is an on my mind that Marius wrote that talks about this topic, and we've had a fair amount of discussion about it today, which I think is interesting. So we've clearly for a long time been talking about the patients who have the low wedge, but we've diuresed them, or they just happen to have a low wedge, but every time they walk across the room, it's 30 and they're really HFpEF. We've not talked as much about, because I think we're afraid of the overwhelming number of HFpEF patients out there, and we don't want them all started on upfront combination therapy. We've not talked as much about this happening, but it clearly does sometimes. And Marius wrote this. He said, really, it's not going to be a dichotomous thing. We could try moving the wedge up or down. We could talk about doing a mean wedge versus an index expiratory. And I'll note that this patient is obese, which is one of the types of patients who do tend to have a lot of respiratory variability. But although she's obese, she does not have hypertension, diabetes, coronary disease. She's in sinus rhythm. She doesn't have a big LA. And this, to us, we thought was PAH. I also know what happens to her. You've written a paper on wedge, and one of the first ones, I think, to talk about that. I don't
And
know
the
if you have any
obesity
comments.
effect,
Yeah.
absolutely. So.
Okay, so we add therapy, and it doesn't actually go all that well. So we add riociguat, we try sub-Q treprostinil. She doesn't tolerate it. We go to IV. We recath her. Our protocol is to get to 40 is our initial goal with treprostinil. We recath, and then if we've not caused the cardiac index to be overtly high or met treatment goals, we'll go up, and we do that. And here's where we are now. So note the year is 2019, and she had a BMI of 50. So any suggestions?
Add another third.
It's 2019. What do I add? We do add a therapy, but it's not a pH drug.
All right.
So she needs a transplant, basically. And yet her BMI is way too high. So, but Ozempic has been approved. So we send her to Weight Wellness Clinic. She gets started on that, and she loses a bunch of weight. But it takes her a while. So it's now 2024. So now what would you like to do? So we've gotten through the transplant eval. It's all happening right at the same time. So we can increase our IV treprostinil, add sotatercept, list for lung transplant, but don't put her on sotatercept. Remember that bleeding risk. Transplant's very worried. Or do B and C both together.
I'm going to B and C both together personally, but
So
you can absolutely make the argument for more of A too. But
yeah, that is what we ended up doing. And she gets better. This is where we are now, and I don't have a next slide. So if anyone would like to tell me what to do next. So here's her cath. RA is 3. Yay. That's like the lowest we've ever seen it. PME is 45. Her wedge is 9. Her cardiac index is still low. It's 2.3. PVR is 8. Her BMI is 27. Her NT-pro finally normalized. So it looks good. Her walk's not terrible. Her RV EDV is still 176 mils, but that's down from 381. So it's impressively better. Her RVEF is 35%, and her TR is mild rather than moderate. So we actually delist her because I wouldn't have listed her in the first place at these numbers, but I don't know what's going to happen from here. That's an awfully high PVR. I don't know.
I would comment that, I have a few of these patients that I've seen forever, and I have a guy who has been my patient for 20 years whose RV still looks like this. He's had a normal pro-BNP for 10 years. He works, and his RV just doesn't get any better, but he has class 1. He is as normal a guy like you wouldn't know, except for he's read from his prostacyclin that there's anything wrong with him. I have some others that longer term on their prostacyclin, they slowly get better. I might increase their treprostinil a little bit. I mean, you're not getting high output. Some people are, I've had some luck with continuing to go up on that dose some.
Yeah, I
more
think
towards
that has
120,
been kind
but
of this trend, like, kind of swings both ways, and I'm interested to see what comes of Artisan, which actually has the CardioMEM placement and looking at a lot of different doses and doses over time. And I have one patient in it, and so I know what's happened with her. But yeah, especially in patients who aren't getting that high output, we definitely can consider that. She's had a lot of side effects, so it'll be tough. And
maybe
she
not
feels
then.
really
Maybe
good
not
right
if she
now.
feels right,
She
yeah.
doesn't want to touch
I have
anything.
and also a personal experience with Artisan with a patient not terribly dissimilar, like definitely, but I think we got to 80. We got basically as high as we could get on treprostinil at her dosing weight, where I wasn't changing her every 24 hours on sub-Q. I tried to keep her to 4. I just think every 24 hours is really hard. And her MEMS data is completely flat. She came back in the analysis of also having a BMPR2 mutation. And so I was really uncomfortable just continuing without anything. And so finally able to add sotatercept, and she has dropped on her MEMS data really
That's great.
impressively. So I think it is something where I want to definitely challenge my treprostinil dosing as high as we can. But I just think there's something.
Yeah, sometimes you
So-
don't get any bang for your buck. Yeah.
And I wonder if some of this RV dysfunction came also from her obesity, if it's more pronounced because she had a BMI of 50, because I have seen that patients that are very obese have RV dysfunction even without.
Yeah, that's definitely a thought. And her exercise capacity certainly is going to be quite a lot different at a BMI of 27 than 50 for sure too. Yeah. So the CardioMEMS, I think, has been interesting. We were not a center that was putting them in prior to Artisan. Our heart failure docs did some, but I've really liked it. I'm the PI in the study. We just have one patient, and we have, especially now in the sotatercept era, where we are sometimes thinking about taking patients off of IV therapy. Is there a role for CardioMEMS there? Because sometimes it doesn't go well, and you miss your window of knowing it wasn't going well. Anybody, any thoughts on that?
I mean, I think I've definitely had, and I think one question I'd love to also pick your brain about too is just this like sort of over treatment and some of these transitions of IV therapy and adding sotatercept. And like, I worry a lot about that over treatment, high cardiac output situation, and sort of that impacting also our mean PA pressures. And how are we going to like kind of interpret that? Is that a clear thing of, oh, this isn't going well? Or is that part of, we are just really in a high output state related to overtreatment that I think we're just not getting from just a PA mean and a PA diastolic alone. So I love it for the Artisan. It definitely made me, we had 2 patients. I have 2 patients on it, one who did not budge until the sotatercept, one who came down beautifully, and it was so cool to see. But I just think there is so much more with the hemodynamics that I'm a big like repeat catheter and get more data and more data. But I think also I'm sure my patients like it better when they can just, put their MEMS pillow up and get that information without doing it, even though I see that as not quite as much information as I want to get.
The other CardioMEMS-like thing that's been interesting to see, I don't know if you guys have seen the small case series. I meant to add that into my talk. There's 2 case series of people starting sotatercept that are published. One's published, one's about to be published, of 5-ish patients. The PA mean drops way faster than it's supposed to. It drops in like the first week to 2 weeks, it's coming down. And it's just, total of 10 patients, but like 5 each. And they show the individual data. And I don't know if anybody
I
else.
don't know. I can't make a lot of sense of that when I think about how it should work. It
Right.
shouldn't work overnight.
They
right?
intentionally made the studies go 24 weeks before because they thought it was going to take longer, not less time. And there's one that I've seen the preprint of that looked at patients starting on treprostinil or patients starting on IV therapy. I don't remember which ones versus sotatercept. And the pressures came down faster with sotatercept than with IV therapy.
Were those patients on prostanoid? The ones you just described?
The first one that is out there that you can look up, Hap Farber is one of the authors on it. I don't remember who the first author was, and I don't remember. The second one that I've seen there were patients starting sotatercept, all but one of whom were not on an IV therapy. So they were mostly on just dual oral going on sotatercept. And then the comparison group was patients starting IV therapy.
Because certainly we see what seems to be some kind of potentiating effect of
Yeah,
sotatercept.
but no, this was not that for the second one that I'm most familiar with. Yeah.
So I wanted to add one comment about the artisan. We have two patients. One unfortunately had a nickel allergy, so we couldn't put the MEMS device in of all the things. But the other one, it was interesting. We stop at 40, kind of reassess, but it wasn't until this patient reached like 65 or something, there was a big decline in the MPAP. And then another at like 95. I probably wouldn't have pushed that fast, that far. But I mean, there is clearly a phenotypic sort of difference. And to go back to your, so I do think the cardiomems might actually be a more elegant way of sort of determining the right approach to each patient or personalizing it. For the sotatercept, I mean, when we were in the Hyperion Zenith studies, the assessments were done every 3 weeks because they would come back to get their shots. But patients would report within 1 week. Not everybody, but there are again phenotypic differences.
Yeah.
Within 1 week, they would say, I'm walking better, I'm climbing stairs better. So there are a subset of patients that are really responding very quickly compared to everybody else.
Yeah.
It tells us that we just really don't know exactly what it's doing, doesn't
Right.
it?
Yeah, I have patients who they can tell, when they're coming due for the next dose.
Yeah.
Clearly, and they report that, that when they're a week out, they're like, I'm not feeling as well. They're really eager to get the next dose.
That's interesting. And do we necessarily have the exactly correct dose for that?
I have an unrelated question to that. In terms of potential side effects, so I would say, in terms of hemoglobin going up, my percentage seems to be way above that. If you ask my nurses, they're like, "Why am I still checking hemoglobin at dose number 10 or whatever?" And I have, instead of like having to stop it and stuff, I like have them draw up a little bit less in their syringe so that they go from 1 ml to 0.9 to 0.8 so that I can keep them on it without really going down. But I also have several patients. I have a couple polycythemia vera patients, a few patients who have MGUS, a few patients who have some sort of myelodysplastic something. And I worry a little bit about whether or not I should put those patients on. I don't know exactly. Obviously, we kick out more cells, and then I see people get iron deficient who probably were iron deficient and it wasn't obvious because they're kicking so much out. But it makes me worry, or say somebody has sickle cell or something. Now, maybe making their blood go up is better, but are we kicking out more sickle cells and not? You know what I mean? I don't know. I don't know if anybody else is running across that. What has anybody tried it or?
I've definitely not
Done
tried
it?
it in my sickle cell clinic, and I would terrify me, honestly.
Yes, and that's how I feel. I'm gonna.
We had one of our sickle cell hematologists do a literature review, and they pulled up a sotatercept-like drug
Yeah, there's a drug that they're
that had
using.
been
Yes.
looked at,
Yeah.
is being looked at, doesn't appear to be causing harm. And there were we have one patient who's, dying of PAH. I know that's very unusual in sickle cell, but legit is. And so I think we were going to start it, but I hearing you say all these different types of patients and me thinking about as we have some unrepaired congenitals with a borderline hemoglobin. I mean, we need a registry that's not the Soteria data is great, but we need these messy patients. We need to know what happens to them.
Yeah.
But on that topic, so yeah, we have one beta thalassemia, and so we came across this. So that the drug is called luspatercept, and it's like functionally like the same drug, although it doesn't have the same active and binding profile. It's not exactly the same. I've actually spoken to like the medical liaisons, and like it's not clear that there's actually any data that other drug has ever been looked at for hemodynamics, like in any model whatsoever. But it's been used for, and I think approved for MDS, for beta thal, and for a couple of other diseases for and myeloma for bumping hemoglobin, like instead of using epogen. So
Yeah, and
I-
sotatercept has like MDS work that's being, I think that's in trial and things like that. So I think I think that just adding the sickle cell component to it, it
yeah,
just
so we
makes
do
me
that.
really, obviously, like if someone, and most of the sickle cell PHIC is pretty mild, high output, lots of, it's not just like a pure kind of precapillary problem, but so interesting.
It's the same for portal pulmonary hypertension. Like I'm very, very concerned of those patients, but I have heard of people trying it, and
Yeah.
I just I just want.
So I have a patient who with a JAK2 mutation who's on sotatercept, low dose, tolerating it fine, but I'm not going to a higher dose. She feels clearly better. But then also the other issue I think with all these activin signaling inhibitors is we really don't know how they work. We do not know the mechanism. We don't know their target ligands. We don't. So you talk to some people, they say, oh, it's because of BMP9. That's why you're getting the benefit. It's binding to BMP9. Paul Yu has a nice paper showing that. That's in bioRxiv. And then you have other people saying, no, all the side effects are from binding BMP9. And so it's just like, and I don't even know about the activins and they're all these, right? So you can't assume class effect because they all bind to a different set of ligands. So it's really challenging to study.
Questions from the floor? Okay, I guess lunchtime.
Thank you.
Thank you.
Regardless.